Hello everybody, we will start together our new series about understanding basic ECG. Our first lecture would be about an introduction to the basics towards understanding ECG and the physiological principles behind this. It's very important to understand that an ECG is a recording of the heart's electrical activity. It is something which we can't see by the naked eye in the heart. When you do an echocardiography, you can see the contraction and relaxation, the mechanical movements of the heart, but you will not see the electrical impulses behind. The output of these electrical impulses would be our ECG tracing, which captures the microscopic electrical impulses and translates them into a readable graphical timeline. First of all, we have a rule of twos. So we have two functional units. We have the atria and we have the ventricles. So the atria are the receiving chambers, which will receive bloods from the systemic circulation as in case of right atrium and from the pulmonary circulation in case of left atrium. We have the ventricles, which are the pumping chambers, which will pump blood into the pulmonary circulation as in case of right ventricle and systemic circulation as in left ventricle. But before having such contractions or pumping of the ventricles, there are electrical events as well. And like we have two functional units, atria and ventricles, we have also two electrical events, which are excitation and recovery, or in another scientific words, they are cellular depolarization and cellular repolarization. And not only two electrical events and two functional units, but also we have two mechanical events, which are contraction and relaxation. So contraction, which is known as systole, which is active pumping of the blood, and the relaxation, which is diastole, which is passive filling. If we look at the electrical events, as we said, it is excitation and recovery, or depolarization and repolarization. So the normal cardiac heart muscle cell is under resting condition is in the polarized state. The polarized state means that the interior of the cells are negative and the exterior of the cells are positive. This is due to discrepancy between the levels of sodium and potassium, and sodium is mainly an extracellular ion and potassium is mainly intracellular one. When the cardiac impulse stimulation starts, this leads to movement of sodium to inside the cell and the potassium leaves outside. So gradually the interior of the cells turns positive and the exterior turns negative, and this is the beginning of depolarization. When this is completed and the whole external surface of the cell carries negative charge and the internal part of the cell carries a positive charge, we call this as complete depolarization, which is complete stimulation of the heart muscle. To return back to the polarized state, repolarization starts, and the opposite happens. Potassium is pumped out of the cell and potassium goes in under the effect of sodium-potassium ATPase, and the interior of the cell start to turn negative while the external surface start to become positive, which is partial repolarization. And when it is completed again and returns back like the polarized state, we call it complete repolarization. Another important piece of information that there is no muscular connection between the atria and ventricles, which means that the atrial muscles are one unit together and the ventricular muscles are another separate unit. Both atria and ventricles are separated by a fibrous ring called the annulus fibrosus. We find all the valves are in this annulus fibrosus, the mitral, and tricuspid and the aorta and pulmonary, which means that all the valves are in the same level. Atria contract together and ventricles contract together as well. So if the atria and ventricles are completely separated by the annulus fibrosus, so how the electrical impulse is conducted between the atria and the ventricles? And this happens as follows. The pacemaker of the heart is the SCA node, in which the impulse is formed and released and conducted through the internodal pathways in the atria to AV node and AV bundle or bundle of His. So AV node and the bundle of His is the only electrical connection between the atria and ventricles, and we'll speak in details about this. And then the impulse will go through the left bundle and right bundles to Purkinje fibers and the ventricular cells. This node is the pacemaker of the heart. It is a dominant pacemaker, and it takes its dominance because it has the highest and fastest firing rate of impulses in the heart. Its rate is 120 beats per minute, but its intrinsic rate usually is 60 to 100 beats per minute under the effect of parasympathetic fibers, which are supplying the atria through the vagus nerve. There is no vagal supply or parasympathetic supply to the ventricles, and this is important to know for the management of arrhythmias. So what happens if the SA node is damaged? The AV node, the atrioventricular node, will take the responsibility as primary backup, and its firing rate is 40 to 60 beats per minute. In complete heart block, when the impulses are completely not conducted between the atria and ventricles, and each one works independently, so the ventricular cells take the final backup and becomes the pacemaker at a rate of 20 to 45 beats per minute. Let's get some important information about the AV node. So the AV node is the only connection, the only pathway, the only path between the atria and ventricles. And there is no other connections between the atria and ventricles. Later on, we'll know about certain pathological abnormality like Wolff-Parkinson-White syndrome, in which there is another extra connection between the atria and ventricles, but this is pathological. So physiologically, it is the only pathway. At the same time, there is physiological delay happens when the conduction happens through the AV node and bundle of His, because this gives time for the atria to fully empty into the ventricle before it contracts. Number 3, which is very important, there is no retrograde conduction between the ventricles and the atria. So it is only one-way conduction, which means if you have a focus in the ventricle producing impulses, this will not return back to affect the atria. The last point, that there is speed limit. The maximum conduction through the AV node is 250 beats per minute. So what happens if the atria is working at a higher rate, like 300? In this case, mathematical block will happen 2 to 1 or 3 to 1. So you'll find the atria at a rate of 300, but the ventricle at a rate of 100 if it is 3 to 1, or 150 if it is 2 to 1. This is very important to protect the ventricle from abnormalities of very high rate which can happen in the atria. So let's summarize what we learned together. ECG is recording the electrical activity of the heart. We have electrical activity of the heart. We have mechanical activity of the heart as well. We have two big units, the atria and ventricle. And each one, the atria, will go into stage of depolarization, followed by repolarization, and the ventricles depolarization, followed by repolarization as well. And the atria will go into systole, followed by diastole, and the ventricle systole, followed by diastole as well. But how this is arranged? Depolarization of the atria will precede the atrial systole. And repolarization will precede atrial diastole. The same for the ventricles. Depolarization will precede ventricular systole, and repolarization will precede ventricular diastole. And what happens when the atria are in a state of depolarization and stimulation? The ventricles are in a state of repolarization. And this means that when the atria is in systole, the ventricles are in diastole, and this will help to evacuate bloods from the atria to the ventricle. And when the atria are in a state of repolarization, the ventricles are in a state of depolarization, which means that when the atria are in diastole and filling, the ventricles are in systole and emptying their content. So what the ECG will record? Of course, it will not record atrial systole, will not record atrial ventricular systole, will not record atrial diastole or ventricular diastole. So in summary, it will not record any of the mechanical events. But it will record atrial depolarization, which is represented by the P wave, and ventricular depolarization, which is represented by the QRS complex, and ventricular repolarization, which is represented by the T wave. And here you will ask, what about atrial repolarization? It is not represented by any of the waves of the ECG. And this is correct because during the repolarization, the ventricle is in a state of depolarization. And as we know, the ventricles are electrically dominant because it has each ventricle has a bigger muscle mass more than the atria. So the atrial repolarization waves are hidden by the QRS complex of the ventricular depolarization. So now we know that the ECG is formed of BQRST waves, and ECG actually is the repetition of the BQRST waves. So all the ECG is just a repetition, but looking from different angles, as we will see later. The P wave is atrial depolarization, QRS ventricular depolarization, T wave ventricular repolarization, and we have something called PR interval, which reflects the atrial depolarization and the conduction through the AV bundle and bundle of His. We have also the QT interval here, which involves all the ventricular stimulation and relief, which is the depolarization and repolarization. It means that QT interval covers all the ventricular action potential. And this is to clarify about the PR interval, that it covers the atrial depolarization plus the delay in AV junction, AV node, and bundle of His. This delay allows time for the atria to contract for ventricular filling before the ventricles contract. In the next lecture, we will talk together about ECG paper and heart rate calculation. Thank you.